Good evening. My name is Rulon Stacy. I am the Director of Graduate Programs in Health Administration at the University of Colorado in Denver. Very excited for the chance to be with you tonight for our second in a series of webinars in our Diversity, Equity, and Inclusion webinar series. Tonight we are going to be talking about how we think about mental health and how we need to change our views in the future. I think you'll agree with me that we have many, many issues on our plate as healthcare leaders and students of healthcare, but none are more important or crucial in this day than this specific topic. We're excited to have you here and thrilled to be able to bring this to you. We could not bring this to you tonight were it not for our partnership with the Colorado Association of Healthcare Executives. CAHE, the Colorado affiliate of the American College of Healthcare Executives, has been with us step by step, and we with them, as we work through this series, and we're thrilled to have them and tonight to introduce you to Mason Colby, who is the Diversity Chair for CAHE. Mason, how are you doing tonight?
Hey, thank you so much, Rulon, and hello, everyone. Welcome to tonight's event. As Rulon said, my name is Mason Colby, and I am the Diversity Chair for CAHE. Tonight's event on mental health is very, very near and dear to my heart. As an openly gay man, I have often struggled with my own mental health in the past. After finally deciding to seek help, I came to the realization that I was so much stronger seeking help than suffering in silence. And it is in that spirit that we gather as a community to further break down barriers in mental health and help people get the help that they need. And that is what this event reflects. So thank you for being here. Lastly, I just want to mention that CAHE is putting together a diversity committee and is actively seeking passionate individuals that want to help put on events like this and make a difference. If you're interested, please contact me at the email on the screen below, and I would be more than happy to meet with you to talk more about the committee. So again, thank you so much for being here, and I'll go ahead and pass it back to Rulon.
Thanks, Colby. Thanks to CAHE for your continuing support. As a past chair of the American College of Healthcare Executives, I openly and strongly encourage you to become affiliated with ACHE and CAHE. The programs are amazing. Their interaction with the university is amazing. Thanks very much, Colby, from all of us at the University of Colorado, Denver. These programs that you're seeing tonight, with this one included, is a result of the leadership of our students. The students we have at UC Denver are absolutely amazing, and they put these together, they run them. There's many of them behind the scenes who work hard. I want to thank the Healthcare Association student leaders, the director of that program, Lindsay Brelge, and our host tonight, Alex Chaldone. Alex is going to be moderating the session tonight. She's going to be one of our upcoming graduates. I've worked with her since I've been here, and I'd follow her up a hill into battle. Alex is wonderful. She's engaged, she's passionate, she's bright. And tonight she'll lead this discussion in a way that will give you information that you'll use in your career and in your daily lives. So I appreciate Alex and the time that she spent with us, and I'll turn the time to Alex to lead the event tonight.
Thank you so much, Rulon. I'm so honored to be here tonight and moderating this event, especially on a topic that is so near and dear to my heart. Healthcare is fragmented, and mental health adds a whole other layer of complexity to that. My goal for tonight is to get diverse stakeholders together and just have a dialogue. It's clear that the current system is not working. We need to figure out what to do and how to change it for the future. Before I introduce our fantastic panelists, I just wanted to go over a few ground rules. this here. First, the recordings and slides will be sent out following the webinar. There is going to be Q&A. We're going to try to save some time at the end, but I really want people to try to participate in the conversation throughout. My peers are going to be sending me some questions throughout as we progress forward. That's a huge component of this topic, is just having open and transparent dialogues. Second, I wanted to also mention that opinions stated tonight and views are expressed solely of the individual unless stated, explicitly stated otherwise, and they're not necessarily the opinions or positions of the organization they work for. You can see the agenda on the right, so we're going to start out with some introductions. In order to get a baseline, I figured it would be fun to do a live poll. It's short, 5 questions. In order to figure out where to go for the future, we need to understand current state. So we're going to talk about existing challenges, some of the current environments, which is the elephant in the room of COVID-19, and then where to go for the future. And then I'll give some time for the panelists at the end for some closing and final thoughts. So with that said, I am so excited to introduce our panelists tonight. Between the 5 of them, they have 8 graduate degrees, 2 more underway. Their work really spans the lifespan, from children to geriatrics, and across multiple different care settings, you know, from carceral health to residential and to treatment facilities. So I've had the pleasure of working with 3 of them directly over the years in different capacities, and then got the chance and was so inspired when I heard the other 2 speak nationally at conferences. So I'm so excited tonight to introduce everyone. First up, we have Dr. Kartiki Churi. She is a telepsychiatrist at Amwell. She shared last week when we talked about this event that she's actually able to see patients across 16 different states, which I think is pretty cool how telehealth has taken off. She's also getting her executive MBA here at CU Denver. Then we have Dr. Greg Elliott. He is a licensed professional counselor. He's currently serving as the president of the Colorado Counseling Association. He's also a professor over at Colorado Christian University. A lot of his clinical expertise and research interests are surrounding suicide, which is a topic that we can't keep avoiding. Then we have Megan Vogels. She is a licensed professional counselor as well as a national board certified counselor. She is the rewiring chief over at Tennyson Center for Children. She has tons of experience working with children, adolescents, and family. Next up, we have Dr. Homer Venters. He is a physician and an epidemiologist. He is currently a professor at the NYU College of Global Public Health and was recently appointed to the Biden-Harris COVID-19 Health Equity Task Force. He is the former CMO of New York City Correctional Health Services and author of Life and Death in Rikers Island. Last but certainly not least is Dr. Aparna Gupta. Aparna is a board certified advanced practice nurse, and she's currently the president of the Pennsylvania chapter of Geriatric Advanced Practice Nurses Association. She's also a certified professional in healthcare quality and a healthcare quality executive that works in value-based care and bundle payment services. So with that said, I would love to kind of get us started here by the poll that Lindsay is gonna launch. And Dr. Churi, while everyone is filling out a poll, I was just wondering, could you share maybe something that you think people may get wrong about mental health or are misinformed about?
Alex, Thank you for the question. And first, I want to kind of express gratitude for this opportunity. I'm really excited to be here and participate in this discussion. That's a really excellent question to start off this discussion. And oftentimes I do find myself having this conversation, not just with patients, but with peers, family, friends as well. When we look at or we think about mental health, there's an abstract or relative quality to it. We cannot touch it like we would for a fractured leg, or we can't see the numbers as we would for blood glucose levels. And oftentimes that puts it at a susceptible sort of a point for stigmatization as well as stereotyping, which has been a lifelong, a long-standing battle for us in many ways. Keeping that thought in mind, oftentimes, somebody who's struggling with depression or anxiety, we tend to stereotype, or we tend to label, meaning as a weak person or somebody who is not resilient enough. So, when we kind of have these conversations, having that thought in mind, I wanted to kind of say that, as I have kind of progressed around my career, and when I initially started off and where I am right now, I've realized how evidence-based what we do truly is. Whether it's making a diagnosis, there's a certain format to it. There's a certain model that we use. We have a number of screening tests. We've kind of gone long ways when it comes to kind of doing some questionnaires to kind of come with diagnostic conclusions, but also the treatment options. I would be curious to hear about from my therapist peers, but CBT, DBT, EMDR, the significant evidence, scientific base to kind of say this works and there's a reason why we do this. And same thing for medications. There's a neurobiological kind of a component to it. So that's a conversation which I find myself having a lot of times, that this may be abstract or relative in some ways, or subjective, but there's a strong evidence based the way we practice in mental health. So that would be my few cents out here.
Thank you so much for sharing that. Lindsay, if you want to close the slide and we can kind of go to close the poll rather, and then go to the next slide, just to kind of, again, provide some background here. So the first question, true or false, according to the the latest state of mental health in America report, Colorado is one of the lowest 5 states in overall mental health. That is, can you please go to the next slide? So that is false. So Colorado is actually number 47th overall. There's a lot of issues going on here in Colorado. It's a complicated system. The best way to describe it would definitely be fragmented. It's across 10 different state agencies, over 75 different programs. But sweeping legislation did pass last week, where they're creating a new behavioral health administration. So not all is gloom and doom there. I think there's a lot of hope for the future. If you want to go hit the next button for the second question. So the second one is actually true. Yeah, far less than half of the people that have a diagnosable mental illness or substance use disorder are actually receiving treatment. Something that I think a lot of people, may also be misinformed about is that, this just started with COVID, but that's not true. You can see with these rates, they've been pretty consistent over time. We haven't been able to meet the needs of individuals for many, many years. If you want to go to the next slide. And so, yeah, unfortunately, it's 70% of counties in America that do not have a practicing child or adolescent psychiatrist. And the scary thing there is that when you look at the numbers for geriatrics or addiction psychiatrists, the numbers are even worse. And a recent report found that across all occupations for behavioral health, we need about 4.5 million more practitioners just to meet the needs of those with serious mental illness or substance use disorder today. So yes, psychiatries, we need more psychiatrists, but we also need a lot more practitioners across many different occupations. Surprisingly, the the number one cited reason why individuals didn't seek care was cost. You know, you can see on the chart on the below right, they also cited that they didn't know where to go for services. I think that kind of speaks to the fragmentation of the system. Just a few other quick notes on this. You know, many individuals go to their primary care doctor for behavioral health needs, and you know, as early as 1996, like the IOM, you know, concluded that, you know, having these separate systems is not good. We need to figure out a way to bring them together. You know, international organizations like the WHO and IHI have been calling for this for years. So again, this crisis isn't new. It's certainly exasperated, but it's been in a state of this for many, many years. We also know that medical costs, you know, for treating individuals with chronic conditions when they have a comorbid mental health or substance use disorder, you know, are significantly more compared to when they do not. And that through integration, we could save a lot of money. And then the economic impact on America, you know, it's estimated that individuals with serious mental illness cause about $193 billion in lost earnings each year in the United States. So there's a lot there, and we've known this for many, many years. And you know, Aparna or Megan, I know we're not going to be able to get into all of the questions, all of the challenges here tonight, because this is just too many. But is there a single, you know, what's the biggest point of failure, I guess, of like why we've known this for so many years? We're moving the needle, but we're not moving it fast enough. Is there the biggest barrier that you think we still have to overcome? And if so, could you share what you think that might be?
Yeah, Alex, you shared some really insightful, statistics. So you pretty much broadly stated all of those barriers and challenges that we have. The challenges that we have today are, I see them in two layers. There's overt and there's the covert. We talk about shortage of healthcare professionals. We talk about, the cost of healthcare. We talk about comorbid conditions. They become worsened when the mental health of the individual is not taken care of or not addressed. At the bottom of this, though, how are we doing as a healthcare community in terms of screening, in terms of spreading that net, and really understanding and normalizing those conditions that almost all of us have at some point in our lives? Anxiety, adjustment disorder, at some point in time, we're all depressed. So how can we spread that net? And to spread that net and to do better screening, we need more healthcare professionals. For having more healthcare professionals, it's really important that we understand mental health is not so much a specialty when it comes to screening. It's definitely a specialty when it comes to treatment and management, and we need to make sure that we're integrating with the right professionals at the right time. However, are we really able to bring a mental health screening to primary care? And what does our integration with primary care look like? So, if you ask me the biggest challenge, it seems like it is a shortage of healthcare professionals. But if we look deeper, peel the onion a little bit more, we really need to bring mental health, wellness, and screening into every interaction with every individual and integrate it a little bit more.
Just add very briefly, Aparna, I completely agree. And two more of the largest barriers that I regularly hear about are just how difficult our systems are to navigate when you're trying to obtain mental health treatment. What is covered under your insurance? What is your out of pocket? And how do you find that provider who's really going to be the best match for who you are as a person and the issues that you need specifically treated? So that is huge, that being in mental health treatment for going on 20 years, it's hard sometimes for me to know how to not navigate the systems, right? So someone whose career is not mental health, so challenging. And then I'll just add, I think just the way we talk about mental health and the questions we ask, we don't like to talk about it. Mason right off the top shared his own experience, and that is wonderful. And I think more conversations and more normalizing that we all have mental health, and that can lead to more people being able to access it.
Thank you both for those insights. I really think you guys hit the nails on the head there. there's just a lot going on. And I am hopeful for the future. So I don't want to give the impression that I'm not, but when you think of all the challenges, it can be a bit daunting. If you want to go to the next slide. So this last question is false. The leading cause of death for people held in jails is actually suicide. And a recent report here cited that 40% of these happen within the first 7 days of admission to jail. Homer, I would really love for you to kind of provide some insight in this. You talk about in your book how the numbers for deaths, in jails and prison, they're a bit colored, and we can't really just take them as is. So I'm just curious, do you think it's possible that, for instance, in 2016, the suicide rate could be even higher than 31%?
So thanks for that question. I think that we have a remarkable lack of transparency about even the most serious health outcome, death behind bars. So there is a lot of parsing after somebody dies behind bars that goes into whether or not the death was a suicide, was an accident, was for some other reasons. These are systems, though, that don't operate like health systems do that we're aware of in the community. We have 5,000 jails and prisons, and they're built to keep prying eyes out. And one of the most important ways is the limiting information about how the environment contributes to death. And so one of the most common practices in these places for people who are in a mental health crisis or any kind of crisis is to lock them behind a door. The DOJ case on the right that I was the medical expert for, we really dug into, in a pretty well-funded system, how the mental health treatment often just amounted to being locked behind a door, even when you were suicidal, and that drives death. And it may not drive suicide that moment. It often does, as you see from the county jail data. But if I can just invoke the horrible, horrible, tragic story and name of a very brave young man, Khalif Browder, who was at Rikers Island, where I was the chief medical officer, and we worked hard to get rid of solitary confinement, but who came in at the age of 16, picked up off the street for supposedly stealing a backpack, was held without bail for 3 years, really physically abused, put into solitary confinement without a profound mental health history before that. He took his life after he left Rikers Island, after they opened up the gates and said, you can go home because the case against you after 3 years just fell apart. There was no case. And he was so brave. He spoke so eloquently all over the country. President Obama invoked his name, many others. But he was so incredibly insightful and brave in sharing his experiences and how damaged he was from the experience, but that damage, he couldn't overcome it. And he really succumbed to it after he left. So I think these numbers are a gross undercount for a whole variety of reasons.
Thank you for sharing that. I think there's so much that we often don't think about when we think about the healthcare system. We often forget about correctional health altogether. And I think, in order to really kind of move forward, we need to think of it as one system. They are part of us. They are all individuals, and everybody should have the same rights and same access. So, when you shared that article, it's beyond appalling. I'm just reading that. So thank you again for providing some insight into that. Greg, I'd love for you to kind of help us learn more about suicide. I know this is, what your expertise is in, and you can go to the next slide here. But when we met last week, we talked about this briefly, and I just asked the question, and you said it's because it's an uncomfortable conversation that nobody wants to have. And so I thought, what better way to start this off? Like, let's talk about it, because it is important, it's preventable, and yet, thousands of people are dying each year because of it. So some just quick facts here, 10th leading cause of death across the United States from 2019. White males make up the majority of it. 90% had a diagnosable mental health diagnosis at time of death. And then, 43% of those didn't have services in the last year. And when you look at the potential life loss before the age of 65, just for 1 year, 944,693. I think that really that number puts it into perspective for me. You can also see the slide on the bottom, broken down by race. It's different. If you want to go to the next slide here. And then, also in Colorado, it's even seems to be worse. We're ranked the 5th highest for suicide rate. It's our 7th leading cause of death here. 14% of suicides in Colorado are for individuals that are, 65 or older, but yet, they have a much higher prevalence of a contributing, physical health issue, which is, to be expected, but, are we not screening these individuals? Why is that going on when you compare it to the number here on the left? Just a few things I wanted to point out here about this before I'd love you to enlighten us, but the current diagnosed mental health needs and express intent recently. So I think that kind of hits your point of, even when we do talk about it, we don't know how to respond. If 33% of individuals, this graph is for, I think from 2008 through 2019, if 33% of them, disclosed that they were gonna harm themselves, before they did it, and then we're still not catching it, what's going on here? Can you help us unpack that?
Yeah, thank you, Alex. It's suicide is obviously, it's a big issue, and I appreciate the information that Dr. Venters was providing a second ago. I've looked at some of the statistics related to mental health in incarcerated populations. Some of what I was looking at today, this was a couple of years ago, but the Cook County Jail system in Chicago, housing about 9,000 inmates, and a conservative estimate there that about a third of them, so 3,000 incarcerated inmates in the Cook County Jail system in Chicago, have diagnosable mental health disorders. Even worse in the LA County system, where there's probably 5,500 inmates that really don't need to be there. They need to be in care, right? They don't need to be incarcerated. They need to be in treatment instead. And so it's no wonder that there's a tremendously high suicide rate. And it makes absolute sense, as Dr. Venters indicated, that a lot of those suicides aren't going to be ruled suicides. Even outside of a jail system, most, like just take Colorado, for example, the determination of whether or not a death is by suicide or not is typically going to be made by the coroner. Coroners are elected officials. And so anyone can be elected, anyone can run for coroner, and anyone can be elected. They don't have to be a medical doctor. They don't have to have any training whatsoever. And there's no sort of outside accountability saying that they have to make a determination one way or the other related to a suicide. And so I spent 10 years of my career down in South Central Colorado, where the coroner may be very well known to the family where the person died. And as a courtesy to the family, they may rule that it was an accidental death and not rule it a suicide, just because they don't want the stigma of a family member dying by suicide to be applied to that family. And so I think the numbers are very underreported, even in Colorado, where we're the fifth worst in the country. One of the slides that you had there kind of showed that increase, and I think it maybe went back about 10 years, but you could go back 20 years and you would still see that increase over the last 20 years of the suicide rate just rising and rising and rising, straight up until the last year that we have data, which was 2019. And then for the first time in about 20 years, you see this very small decrease. But that decrease is really, first, it's very small, and it certainly is within the margin of error when you consider the problems with reporting and determining the cause of death. But that decrease is also completely accounted for just in the decrease that you see among the Caucasian population. And if you look at the non-white populations, you'll still see the increase in suicide going up. And so I think that we have some equity issues there, and access issues that are still impacting some of our more vulnerable populations. And then just to sort of close out what you asked me, I think that there's still a tremendous amount of stigma. And as human beings, maybe from an existential standpoint, we don't want to talk about suicide. It's an uncomfortable topic. We don't want to sit down across from another person and really listen to them talk about their reasons for dying, and listen to them really talk about what them feeling like that they're a burden to the people in their lives, and that they really feel like that their parents would be better off if they would just kill themselves, and that no one is really going to miss them. They don't have a purpose. There's no meaning for them to be here. And that's uncomfortable for people to sit and listen to and to try to really engage with. And that's true if you're just a person, not a mental health professional. And I think it's true for mental health professionals as well. And so I think as mental health professionals, we really have to be intentionally and intensively trained to work with suicide as a clinical issue. And to a large extent, I think we're not sufficiently trained. And so in those cases, a lot of times, even with mental health professionals, maybe sometimes with medical professionals, the red flags are there. The client or the patient is kind of waving those red flags and dropping hints and saying, like, this is an issue and this needs to be talked about. And the clinician, for whatever reason, isn't comfortable going there. And so we simply don't recognize the signs and we just don't address it clinically. And that's why you have so many of these suicides occurring in patients and clients who have been seen by a mental health professional in the last 6 months and have been seen by a medical professional in the last 6 months, but nobody saw the signs and nobody addressed the issue with them and connected them with the appropriate level of care. And then unfortunately, that person dies by suicide.
Thank you so much. I know it's a topic that we all need to learn more about. So I really, really appreciate you sharing your expertise with us. I want to kind of unpack a few of the other challenges here. The first one, just overall inclusion issues. This is kind of a really complicated subject and, a series of questions, but just kind of want to throw it out there and then hear you guys' thoughts and intersections with it. So we keep talking about, needing to integrate, but the behavioral health system and physical health system are so separate. And then we even have rules, regulations that make the data sharing even further. And then we've got correctional health in its own separate entity over there. And then when we talk about the whole person, is it fair to ask the primary care doctor to actually treat the whole person when they don't even have access to the whole picture because of those regulations? And then I think kind of connected to this whole issue of inclusion is just the language that we use about it, calling it what it is. And, are these structures in place, really contributing to this? And are they going to prevent true inclusion from happening? Do you guys ever see a future where it'll be one health system? It won't be correctional health, mental health, and then the health system or healthcare in America? Just want to hear your thoughts on that. And yeah. I think you're on mute.
Yes, I am. Thank you. I think you stated it really well when you said, I'm going to unpack this, right? There are a lot of loaded statements here. Where to begin? Let's begin with the intent and the spirit behind person-centered care. The concept of person-centered care is not new at this point in time. It was maybe a few years ago. Most of us now understand what it means and how to implement it. And there are certain systems and policies in place at this point in time. Are we successful though? You just said it. We have these different health structures, mental health, physical health, correctional health, and then there's more variations of those as well. We can dig deeper, correct? So, and then the second layer of data sharing comes in as well. So there are improvements being done as far as we see. I mean, with the health information exchanges, with interoperability, there's light at the end of the tunnel. We're not there yet. What are some of the things we could maybe think about collectively, right? We talk about caring for tip of the iceberg. We talk about wraparound care. In 2014, National Council on Quality Assurance, NCQA, included mental health integration as a part of accreditation for patient-centered medical homes. So they said that, if you'd like to be accredited as a patient-centered medical home, make sure we'd like to see how you're integrating depression care management, how you're integrating mental health and wellness. 2014 that happened, and right on the heels of that, USPSTF then recommended mental health screening as a grade A recommendation. There is work being done, but it's really important for us to keep on our radar as we're providing care at the front line, thinking about that integration piece, wherever we are, whichever part of the mechanism we are, whether we're in primary care or in specialty care, that reach across the aisle, hold hands, and share as much as we can.
Yeah, I would just add as well that I think mental health care is really highly regulated in a lot of ways. There's a lot of oversight. There's a lot to do and document. And I think that can be really frustrating for providers and certainly families who have to be asked just tons and tons and tons of questions and things, right? So I think that's really frustrating. But I think at the same time, as I reflect back, there are some tremendous benefits that I, because of regulation and policy, started to integrate into my practice because I had to, and that were helpful. I had never thought or was trained to ask about physical health or to ask about dental health. And now it's regular. I just ask, when was the last time you saw your primary care physician? Oh, you haven't seen them in 8 years. You haven't been to the dentist in 6 years. I wonder if there may be some health conditions that are contributing to your mental health symptoms. And also we've got to take care of you as a whole person. So let me help you navigate those systems, access those providers, and then let me coordinate with them. I have learned a tremendous amount, and I think that the field is pushing more into that integration, even though maybe it can be cumbersome at times and it's not perfect. There is better improvement happening and better quality of care, which makes me hopeful.
Thank you, guys. I think the last challenge that I would love to get your insight on before we talk about the current environment is just, in regard to the workforce that we talked about earlier. We know there's shortages, we know they're everywhere, but furthermore, then the current workforce does not even come close to representing what our population is like. On top of that, that kind of alienates people of different cultures, ages, genders, to name a few, of even seeking care when they can't find anyone that is a behavioral health provider that, looks like them, has the same values as them, identifies similar to them. And then, to kind of go on that a little bit, further. Well, I guess let's start there. How do we get people interested in this field when there's so many challenges? Obviously, no one goes into mental health to make money. I think that's kind of well known. People want to make a difference, but then you have some, parity issues where you hear that primary care visits are, reimbursed at such and such rate higher than behavioral health, and patients that are trying to find providers, they're going out of network in order to do that, and then that increased their cost sharing. There's just a lot that are tied to the workforce issue, and just want to figure out where can we start with that. Greg, I guess I would like to hear your opinion on that, just from a policy standpoint with the work that you're doing with CCA.
Thanks, Alex. And one of the things that the Colorado Counseling Association is working on pretty hard right now is tied into what you've asked here, just related to reimbursement. The Medicaid funding for mental health is allocated through regional accountability entities. And those raise short have been slashing the Medicare reimbursement to master's level counselors here this year. And so we've been in responding to that, working with the legislature. But one of the things that I noted with that is since I'm in the Denver area, I'm monitoring this, and CCHA sends out a notification that they are slashing the Medicare reimbursement rates to counselors, and that they're going to require approval for more than 20 sessions of counseling, which I think gets really sideways with the parity laws, quite frankly. But then, a month later or 2 months later, I get an email from Dora saying, hey, we desperately need providers to see Medicaid clients. And I'm thinking, well, of course you do, right? Because now the rates are so low because CCHA just cut the rates that it no longer is feasible for counselors to be seeing Medicaid patients at all. And, because it's not just if the rate is whatever it is, $50 an hour, that's not just $50 an hour that goes into the clinician's pocket. $35 an hour of that goes towards their lease. And the rest of the overhead. And at some point you cross a threshold where you're losing money by seeing that client. And while a lot of counselors and a lot of mental health professionals are going to be willing to see a certain number, a certain percentage of clients pro bono, certainly professional counselors are encouraged to see a certain percentage of clients pro bono. It's just not financially feasible if you want to stay in business as a private practitioner to be able to do that when the rates are so low. And so these rate cuts that we see, from the regional accountability entities, ultimately what that's doing is it's taking professionals out of the market, and then our Medicaid clients are unable to find a practitioner when they reach out to someone for help. And I think that's problematic. The second thing that I would mention just really quickly, kind of related to access, is the Colorado Counseling Association is also working really hard with the American Counseling Association on an interstate compact right now. And it's in the early stages, and this is going to take us a couple of years to pull off. But what this basically will do, and I think Colorado will be a part of this probably next year, is create very, very similar to the interstate compact that nurses and physical therapists have, where if Colorado is in the interstate compact and Kentucky is in the interstate compact, if we have a counselor from Kentucky that's licensed as a professional counselor and they want to move to Colorado, they can do that, and the transfer of their license will be almost automatic. And so they'll be able to make that move and continue practicing and start their practice in the state of Colorado kind of seamlessly. And we see that as being really important from a licensure portability standpoint, moving us a little bit closer to what physicians have and nurses have and some of the other healthcare professionals. But there's a lot there that I think that's really important that needs to be worked on. Those are a couple of important things that CCA is focused on at the moment.
Thank you. So I think that's a perfect transition to talk about, other work that, the panelists are doing. Homer, I would love, for you to share some of the COVID-19 stuff that you've been doing over the last year, going across the country, what you've been seeing, how that impacts, correctional health as a whole, mental health, and where you see that going and the impacts that it's going to have for the future.
Sure, thanks. So about a year ago, maybe 14 months ago, I left my job running a nonprofit, a correctional health nonprofit, and really just so I could focus exclusively on responding to COVID in jails and prisons and immigration detention centers around the country, because it was, pretty clear it was going to be a disaster. So in this time, I've been to I don't know, I've probably been in about 40 facilities around the country. I've probably done 25 or 30 court-ordered inspections where I go in to look and see what's happening with COVID, make recommendations about what's working, what's not, and then, you know, as part of litigation or other efforts. And so, you know, I think that as people are generally aware, the rate of infection is much, much higher behind bars. And the rate of mortality from COVID is much higher. Access to vaccines has been delayed. One of the really striking things I'm seeing now, though, is as we get vaccines into these places, the rate of vaccination among the correctional staff does not get above 50%. Most places have had access to vaccines since January for correctional staff, and we're just not getting above 40, 50% almost anywhere. In terms of mental health, the impact has been profound, and it still has not been appreciated at all. Because these are places that solved most problems with isolation, with throwing people in a cell and locking the door, whether it was acute intoxication, psychosis, suicidality, all those things are health problems that these 5,000 boxes around the country have learned for decades to react to by locking somebody behind a door. Along comes COVID, and it's almost purpose-built to lock people behind doors for a lot of reasons that you would think of, medical isolation and quarantine. And so it has been an incredibly isolating time. I just was last week, I'm running from one prison to another. And last week, a person who told me, or the week before, said, I've been in 10 prisons, and this quarantine was the worst thing I've ever experienced. And he had been in solitary lockdown for like punitive reasons in a lot of places. So I think that because we haven't known how to handle it behind bars from an infection control standpoint, we've used that same tool. I think that there are many facilities around the country that have just locked down the whole building, right? Locked down whole housing areas. And slowly but surely that is lessening up a little. But people during that time have been removed from their families. There's been no visitation for a year. Visitation is slowly starting back up. But these are things, these problems, the trauma of seeing people around you get sick and die without getting care, the trauma of being isolated yourself and from your family, the little like, you know, the dynamic strengths that you had going into this, or the static strengths you had going into this, either of them, that's not yet been appreciated at all. Really, these places are just reeling and thinking about who's dying from COVID today, who's getting vaccinated. So I think we have yet to learn really what is the impact. And remember, everybody's going home with very few exceptions. And so they're going to come home with this trauma that's going to be quite profound for them, for their families, and for the communities they go back to.
Thank you. Megan, do you have anything to add? You know, I know you've done a lot of trauma work in the past, and just the impact on children, you know, overall, and what this means for the future. You know, I know it's been hard for me, you know, but I can't imagine how devastating that is, you know, for children that they've been placed elsewhere, or they've lost a loved one. It's really, COVID has truly, you know, uprooted everyone's world, including children. And I think we often forget to think about the impact that it's going to have on them long term.
Thanks, Alex. I'm thinking a lot just about the access and equity for kids out there, right? Like, we know that kids who have supportive families, who have stable situations, who have access to technology and to schools, they are they're certainly doing significantly better than kids who are struggling, who maybe are struggling with food instability, with housing issues, with parents who maybe are struggling with jobs and who don't have the same access to be able to go to school or to access healthcare. We certainly see that is a barrier for families. Telehealth has been amazing. I think we're seeing so much as a culture, right, that we are comfortable using these different platforms. We're able to engage, and really, I think there's a little bit of a silver lining there in terms of just, I think someone said this last week, that goodness gracious, like we have moved forward with our ability to access telemedicine. Like 10 years of progress has happened in like 30 days, which is pretty phenomenal. So I think that has certainly been a positive thing. And we see that access still being a problem for many families who don't have that same access to Wi-Fi or pieces there. So a little bit of a silver lining, and we're going to be seeing that the impacts of this past year, 2 years for decades. And I think it'll be interesting as the data comes out, the medical implications, the mental health implications, and just how this compares to other sort of terrible world events.
Thanks, Kartiki. I would love, for you to add, just your experience as a telepsychiatrist during this time, what you've seen, before we switch gears. I think, we all know COVID has had a profound impact, but if you could just kind of tell us from your point of view, how it's changed your work and where you see the future. I'd love to hear that.
Yeah. Thank you, Alex. So, I shifted to telehealth just before the pandemic. So it was like a couple of months prior to the pandemic. I made a change in my work, and for different reasons. One was I was really kind of interested in seeing what's beyond, kind of wanted to practice beyond these, kind of have that interstate experience as to what's beyond Colorado or what's beyond what we do here and what's working where, right? The regulations, especially some regulations related to gun control or regulations related to hospitalizations, and they're different in different states, which was kind of interesting for me to see. I was also interested in providing care to the underserved remote areas, and that has been probably the most meaningful part of the work over the past year, I would say, especially with the pandemic. I think one thing that the pandemic, there's been so many hardships with the pandemic, but one thing that really and truly has kind of put universally all of us in that situation, the isolation that we talked about, but given us some time to introspect and say, okay, I'm not doing well. And it's okay to say that I'm not doing well. So there are a number of patients who reached out saying, hey, you know what, I've never seen a psychiatrist. And you look at their case and, oh my gosh, this person really needed care for so many years prior, but finally they picked up the courage to pick up the phone and make this video appointment. I think also doing that visit from their home gives them a space of safety when they're trying to pick up that courage and be vulnerable and say, this is my story. So I have had, I think, a huge number of patients who've said, hey, this is my first call and I've been struggling with this for a really, really long time. So that's been really meaningful for me to be able to actually experience clinically as well. As we talk about some of the positive things, we also do have, we've made great, I really kind of appreciated what Megan said, we've made such great advances in this past year. Having said that, there are also things that we probably do need to be aware of, which will probably make things a lot more accessible. It's a tool, telemedicine, one of the tools that we can kind of make work for our patients as well. You brought up the point, Megan, about digital inequity, which is huge, and we talk about providing care via telemedicine to rural or underserved areas. However, it's interesting how many folks do not have internet access or computers. I actually read an article today morning which pointed out about 17% of youth do not have access to internet, and about 14% do not have access to computers, and that's a really high risk population that we need to be providing care to. I think other factors, reimbursement. Greg, you pointed out the reimbursement and licensure as well. I think we are several steps ahead than what we were prior to COVID, but still streamlining between different states and really kind of bringing it together. So yeah, I think we've come a long way, but we also have long ways to go.
Thanks, and I think that ties great into both Aparna's and Megan's work of, when you're talking about reimbursement, the future, is value-based, but then, Megan's trying to kind of reinvent or prevent rather, the child welfare system here, and then how do you do that when there are these challenges? So, Aparna, Megan, I welcome any further thoughts on that, and how the work kind of relates to one another.
Yeah, thanks, Alex. So certainly we're living in a chasm right now. We're living in a chasm from, moving from fee-for-service, moving towards value-based care, moving towards outcomes-based care, and that's where reimbursement is moving as well. We're not there yet. And so as we're not there yet, how do we sustain ourselves and how do we sustain our work in a way that we can get there? You've done a great job. You've sort of talked about some very foundational issues here, sharing of data, for example, the administrative burden of quality metrics, for example, right? So it does come back down to reimbursement rates. It does come back down to what are the kinds of incentives and what are the kind of quality programs that are there that will help move providers towards actually delivering care where care is required, and which comes down to the issues of equity. So integration is where I see, there might be a little bit of light at the end of the tunnel. CMS over time, if you look at the revised physician fee schedule every year, more and more they're focusing on integration and providing codes for integration of mental health and primary care. And this year they've actually provided codes for making permanent telehealth delivery as well. I love Megan's thought process around rewiring, and rewiring is what we need towards value-based care.
Aparna, you're talking my language too. The work of rewiring, just briefly, and I could talk all day about it certainly, but really briefly, the idea for rewiring is that there's so many kids and families out there that are struggling, that are wobbly, right? And that because of various reasons, equity being one of them, access being another, knowledge and information, and poverty, lots of factors end up coming to the attention of the child welfare system when there aren't issues of child maltreatment, but poverty can be a significant driver into these systems. And so the work of rewiring is saying this is not okay. We can do better, and let's change the system so that access, information, social safety nets, right? Families are not isolated, but they get the things that they need when they need them. So they don't have to go into systems that they don't need to. They don't have to go into juvenile justice or the adult jail system, because that is a safety net that will ultimately capture them, not a safety net, right? But somewhere where they can end up. But really, if we can reduce the flow of those kids and families into child welfare, we can have better outcomes for those who are in the system, so that those who really do need to come to the attention of that system, they can support and handle and give these families what they need and get them out of the system. And that rewiring is trying to, through a combination of data collection and outcomes and demonstrations, that we can ultimately change how the sector is financed, so that more funding is available upfront for prevention or early intervention when people actually need that. Now that's like a massive sort of movement of systems that include public health and Medicaid, Medicare, and insurances and child welfare, and pulling together all those 10 different departments in Colorado to say, let's all do the same thing together, right? So we're intervention agnostic, but just focused on those outcomes. How can we show that new different supports or things delivered at the right time can really support families for a true system of child and family well-being.
I love that. Homer, I have a question to kind of build off that. When we think about individuals that get released from jails and prisons, what about ensuring we get those individuals the right care at the right time? We know the comorbidity rates of mental illness in those individuals, and ensuring that there's proper follow-up. Do we have to kind of change the way, jails and prisons are financed in the insurance system in there? How does that intersect and interplay?
Sure. I think that people generally, might be aware that one of the reasons we have such bad care behind bars is because we've left this job to people who run jails and prisons. And it comes down to money in our country, right? So the Social Security Act precludes the use of federal funds for people who are in these places. So then it's the lowest common denominator in terms of how much is a sheriff or a Department of Correction going to get for money for just basic health services. That means that reentry work, transitions work is very sparse in prisons. It's almost non-existent in jails. And as a result, we have very bad outcomes afterwards. Really a dramatic spike in mortality when people leave. A lot of that actually is because of lack of evidence-based access to methadone, buprenorphine, but also higher rates of other physical and behavioral health problems. I do want to add in a caution though. I think that we're going to hear a lot about in the next year or two, figuring out how can we get Medicaid funds for the final 30 days for people to use those funds for reentry. I think there's virtue there in terms of connecting people to care, even starting care behind bars. That's all good. What I am very worried about is that we have 3,000 county sheriffs in this country that are right at the center of these disparities, and shoveling more money their way without the same kind of transparency and oversight we expect in an ambulatory care setting, inpatient psychiatric setting, is going to blow these disparities wide open, even worse. And so when we talk about how can we get better care behind bars, the first step is to not put people with serious mental illness behind bars. The first step is to get people not into some law enforcement health construct that has 1,000 swords of Damocles hanging over them if they have the wrong kind of urine test result, or they have a predictable relapse of whatever their health problem is. It's to get them to treatment, not to get them to some special law enforcement version of treatment. And that means keeping them out and getting them into the same treatment pathways the rest of us use. I think there are a lot of ways to improve correctional health care, but correctional health care gets a lot easier when you aren't asking guards to figure out how to manage with some correctional health doctors or nurses or psychiatrists or social workers, a whole cohort of people that really need much more intensive inpatient treatment.
Alex, that it just makes me think what Homer was saying, really resonates for me as far as what some communities are doing now, as far as community mental health being dispatched with the sheriff's department, right? Because what we don't want is the sheriff's deputy responding to a mental health crisis. That typically does not end very well. But, now we have these behavioral health dispatch teams that can go out, and if we know it's a mental health call, then they partner that sheriff's deputy with a mental health professional, and they go out and you can have that person de-escalate the situation, find out what the need is, get them connected with care, and maybe the sheriff's deputy is there as backup, but a lot of times they're just going to kind of be standing back and monitoring the situation. And it's a much better design for how to respond to a mental health crisis than sending in cops with guns, even if they have some training responding to a situation that really doesn't need that level of intervention. What it really needs is someone who can de-escalate and figure out what the need is and then get them connected with the resources.
I think that's a perfect transition into the whole 988 movement. And what's that going to do? I think that's going to be a huge change. I know it's going to take a while to implement and whatnot, but I do think people that are experiencing a mental health crisis should have an expert in that to speak to instead of just a regular health professional. So just wanted to kind of throw that out there and get you all's thoughts on what that's going to do to our system and workforce, frankly.
Alex, I can, just kind of briefly touch base. I really appreciated how you said, that it needs to be a professional. It needs to be a professional who needs to be present at that point of time. So meeting the patient at the time that they need us to meet them and at the location that they need us to meet them is such an important part of, what we do. Unfortunately, the lack of access sometimes becomes a huge barrier for that. So kind of the care coordination piece is what I oftentimes kind of say, the triaging and the care coordination while a patient is coming in and while a patient is being discharged out. So kind of what can we do to improve those processes so there's a smoother transition? A patient is being discharged and what are their needs, or a patient needs to be hospitalized and what are their needs and what that community needs at that point of time. It could be advocacy for the insurance. It could be the food insecurity. It could be workplace unemployment due to COVID or other situations, and what is the need and what's the psychosocial factor behind what's kind of going on, and kind of really meeting the patient where they need us to meet them is kind of a key to, one of the keys to kind of that problem.
I think it's also it's both helpful, and I think that the 988, the suicide prevention hotline, in terms of delivering services to to people, right, and to people who might be suicidal in a moment. We know that a lot of times suicide, and Greg probably can speak better to this, but suicide it can be an impulse. It is something that is that can be very much acted upon, and is not really what a person really isn't intending to do. It is an impulse that they're acting on, and then and they can be successful in completing that suicide. So I think having that hotline available to people in that moment could be huge in terms of deterring suicides from actually happening. And I think the symbolism of it is also really, really powerful, that we are saying, if you have a medical emergency, you can call 911. If you are feeling suicidal, you can call 988. This is important. This is crucial. We're talking about it. And I'm hearing from people that are not in our fields who are asking me, like, what is this about? And what do you think about this? And that they're hearing about it. It's out there. So I'm so excited. I think like Greg, I'm always willing to engage in conversations about suicide, because I think it's giving people language, and it's giving people information that they can use, and it might support them, or it might support someone that they're connected to. So I think it's just a really amazing thing that we are here. This is beginning.
I'm excited about it too, Alex. I think it's a tremendous opportunity, and I think it says a lot that we've been able to kind of take this step and get this phone number in place. I mean, we've spent a tremendous amount of effort over the last few years, marketing the National Suicide Prevention Lifeline number. I've got like 10,000 of these, and I give them out at trainings and stuff like that. The 1-800-273-TALK number, but 988 is just that much easier to remember. And so I think the opportunity there is, to get that into the national discourse to the extent that everyone knows what 988 is for, just like everyone knows what 911 is for. And so we've got 5-year-olds that are dialing 911, right? Because they're taught in elementary school what that number is for. And I think that's the opportunity there, that we get that sort of into our DNA as a country and as a people, to understand that if there's a mental health emergency, we call 988. If someone is suicidal, we call 988. And if that makes it that much easier for us to have that conversation about suicide, because maybe we don't feel so helpless then, right? Maybe that's some of the hesitancy in engaging someone in that conversation, is because if I ask this person if they're suicidal and they say yes, then I'm not going to know what to do next. And now maybe I'm willing to ask that person, are you thinking about killing yourself? Because if they say yes, I'm like, well, let's call 988 together, right? I know what I can do once that number goes live in 2022. So I think it's a real opportunity, but I don't think it'll be automatic. I think it's going to require some work on our part to take advantage of what that opportunity represents.
Homer, do you think that, if we do some mass, marketing and, beyond just, suicide, but just mental health emergencies, do you think that can kind of stop people with mental illness from getting getting locked up for things that really they shouldn't be in there for to begin with, and maybe kind of help on that side as well? Or, and if not, what can we do on the correctional health side to try to reduce that?
Yeah, I think on the front end of things, it is critically important to expand all of these ways where we can bring treatment to people who right now get a law enforcement response. And so there are myriad ways that counties and even some states are approaching this. So I think that that's critically important. Where I spend most of my time is behind bars. And, if the whole country does what New York City did, which is cut its rate of incarceration, more than in half. We have over 2 million people incarcerated today. Let's say we still will have lots of jails and prisons, unfortunately, with people in them. And so we still need to force ourselves to contend with what happens to people behind bars and think about access to evidence-based care. And this is where I think our national structures, the CDC and our state departments of health, have been completely AWOL. These are evidence-based organizations that promote health and they track health outcomes for all sorts of things. And if we just take the one outcome of suicide, it's just incredible to me that the most incisive investigations into mental health conditions behind bars actually occur by law enforcement agencies like the Department of Justice, because they think people's constitutional rights are being violated. Well, where has the CDC been? Where are these state departments of health? When people are dying behind bars from suicide. I could pick any number of health outcomes: traumatic brain injury, diabetes, where we have really strong evidence-based approaches to finding these problems, mitigating and preventing them, treating them. But all of those evidence-based structures are only too happy to be uninvolved in healthcare and the plight of people and the health of people behind bars. And so we have to force, and we have an opportunity right now with the CDC being involved in COVID behind bars. We have to force our state DOHs, county DOHs, and also the CDC and HHS to stay involved and get more involved in promoting better health outcomes, because that brings a whole nother group of voices to say, yeah, of course, seriously mentally ill people probably shouldn't be behind bars, but we need these health organizations to help us with this. So it's not simply this mass incarceration law enforcement debate, which is an important debate, but that goes on, trundles along without the forcing health organizations to bring their voice to it.
Thank you. I know we've only got 15 minutes left. There are a few questions here in the chat. People want to talk more about suicide, so I think that's great. So Greg, I guess I can kind of let you take maybe one of these, but with specific populations. So mention the military and then on college campuses. I know on college campuses, Active Minds exists. I joined that back, 15 years ago during undergrad, but I'm not sure. Could you tell us about the military? Any efforts to better support that population during the pandemic?
That's a great question. My answer to that's kind of yes and no. I'm not aware of any specific efforts related to the pandemic and suicide in the military, but we've got a really strong evidence-based training program called the Applied Suicide Intervention Skills Training, or ASSIST for short. It's been around for a while. It's through a company called Living Works International that's based out of Canada. And that particular training is a 2-day training. And I know, obviously suicide has been an issue in the military for quite a while. There was one Army base, and I'm not going to be able to pull up the name of the base off the top of my head, a couple of years ago, maybe 3, 4, 5 years ago, where the incoming general that took over that base basically made this his #1 priority and said, everyone who's military is going to go through ASSIST, and I'm going to make it available to every non-military civilian who's also associated with the base as well. So pretty much everyone went through it and basically reduced the suicide rate to 0. And so you take one of the one of the Army bases that's absolute worst for suicide rate in the military, and then you take, you know, the commanding general coming in saying, we're going to do something about this, and then they implement that certain amount of costs associated with that, and they basically reduce the suicide rate to zero. And so I think, you know, one aspect of that is that that was a top-down approach, right? And I think where you have bases that continue to struggle, I think you have to look at who's over those bases and look at how committed they really are to making a difference in those bases. I think, you know, when you look at the Zero Suicide Initiative, which is our national suicide prevention initiative for the United States, that's one of the components of that, is that it's got to be, it needs to be collaborative, and it needs to engage everyone in the organization, but it has to have the buy-in at the top of the organization. If we don't have that, it's not going to be effective. So I'm not aware of anything that's been going on within the pandemic. I know one of the silver linings, I think Megan was talking about silver linings from the standpoint of the pandemic. One of the silver linings for me personally is I'm a certified AMSR trainer. That's assessing and managing suicide risk. And that's typically been a training that's only been allowed to be done face-to-face. That's through the Suicide Prevention Resource Center. But they were able to pivot really fast after the pandemic hit. Within a few months, they were able to make some changes to that training and recertify all the trainers so that we could do it online. And I think that's been the last 3 of those that I've done online. And I think that's been so successful that probably once we're back to normal, whatever that is, we'll continue to be able to do those online. And that's really opened that up to a brand new audience for me, and allowed me to train a lot of different people. And that the AMSR training is more geared specifically towards mental health professionals, whereas ASSIST is geared towards anyone who might come in contact with a suicidal person, which is literally all of us.
Yeah, regarding suicide in the military, I came across, maybe about 7 or 8 months ago, an organization called Give an Hour, which started originally as a way to provide no cost mental health treatment to active service members, veterans, and also their loved ones, as a way to reduce the stigma that many in the armed forces feel in terms of accessing any sort of mental health care. And this organization has been around for a while, and I think I'm not sure exactly what their impact looks like. I know certainly that they track hours and they track, you know, people served and all of that. But I think a lot of the mission of that organization is amazing, and I'm happy to volunteer for them. And also how easy it is for people then to access. Like, they go on the website, they put in a couple search bubbles, and they can get linked to a credentialed, licensed, qualified therapist for the issues that they're needing. And I think how amazing that exists. And also, can that exist for everyone, right? Can we just expand that for everyone to say, like, I need some help? The first day that I was credentialed and available to take clients, I received 3 calls in an hour. And I think, holy moly, like there's so many people out there. And so I think of the work that that organization is doing. And I just wish that this could be something that we could all access, because we all struggling.
This is not exactly, it's a little bit tangential to what you were just saying, Megan, but I thought about it as you were talking. A couple of my supervisees are associated with an organization called Open Path Collective, which is basically Psychology Today for low-cost counseling. And it's really growing right now. And so for people who maybe don't have insurance, or mental health care is not covered by their insurance, this is an opportunity for them to still be able to access counseling and receive that care. And the rates are negotiable, but it's all at the lower end of the continuum as far as what you might pay for an hourly rate for counseling. So that's available out there as well. Open Path Collective.
Thank you for sharing that resource. I guess I kind of just wanted to open it up. I think we answered most of these questions in here. But just for the panelists for some final thoughts here. We know knowledge is power, and it's creating new ways of doing things that haven't been working. And I think this conversation tonight has been a great catalyst in that. But just some final thoughts on advice and where we need to go in the future, and how we can finally make a difference and change the system. And so I'd invite each of you guys to have a few minutes and just kind of share your thoughts and what's the most important takeaway for individuals here.
Alex, first of all, let me congratulate you. This has been a very eye-opening session for me as well. Being in the presence of experts and renowned folks in their field. So a lot of difficult issues have been brought up, and we've really tried to peel the onion and try to come up with solutions, moving from problems to solutions. One of the things in my work with bundled payments and work with geriatrics as well, so going from provider to payer, I find always the need to come together as partners. So far, it has been, payers, providing reimbursement and providers delivering care at the front lines. The actual magic happens at the front line. Lives are improved, population health, healthcare cost, outcomes, all of that happens at the point of care. And so the more that we recognize that and we bring partnerships together, I see, point of care as a lab, if you will. There are many pilots, there are many different kinds of incentives and reimbursement sort of testing that is occurring. So, going back, if we're a provider working with our payer, if we're a payer reaching across the aisle to our providers and say, hey, wait, this is the data that we're seeing. Let me share this with you as best and legally, obviously, within the regulation scope possible. But let's think about ways, out of the box ways, because we are moving towards value-based care. So it'd be great to sort of bring person-centered care, integrate as a healthcare team, but also bring the payer and the provider together so that we're all in it together for the right reasons.
Aparna, thank you for that perspective. I couldn't agree more. It's just, and you beautifully verbalized it. So thank you for that. I think to add to that, I would probably say, when it comes to partnerships and collaborations, all these stakeholders, which it's mental health professionals, it's the community, it's the systems, whether it's a school system or it's the jail system, bringing all the community basically where the patient is, and that partnership is important and kind of making it work for that population and their needs. So that when it comes to collaboration, there's a larger level which comes with the payers and the insurance, and there's this other which is kind of in the front line with what the community's needs are, and all the stakeholders, which including the patient and what their need is at that point.
Craig, Megan, Homer, whoever wants to go next, share your final thoughts. Don't all jump at once here.
This will probably make me sound a little bit like a cliche, Alex, but I guess my final thought would be just to call out for the folks that are with us tonight to not forget their own self-care. The pandemic impacted us as well too, and I know for me, in my primary position as a faculty member, where I'm used to being in a classroom and interacting with people face to face, and for the last 14 months I've been doing the Zoom thing, and it's not the same. And so I know that as a professional, it's impacted me in some ways. I know it's impacted my students, and as I work with my supervisees and my clinicians, they are rolling with it, and they are trying so hard, and they're providing care, and they're trying to meet people where they're at and provide the best care that they can. But it's been a hard 14 months, and a lot of programs, ours included, we weren't training people how to do telehealth until everyone was doing telehealth. And then we were like, okay, how do we do this, right? You know, and everyone's just trying to roll with it and do the best that they can. And, you know, and it stretched out much longer than I think we thought it was going to, you know, back during this time in 2020. And so I guess all that to say, it's been a hard 14 months and we can't pour from an empty cup. So just being really intentional. By self-care, I don't mean a spa day. I mean, just being really intentional. It could be a spa day, I guess, if that's the thing, but being really intentional about, you know, what do you do to recharge your battery? And that doesn't have to be a day off. It could be an hour, it could be 20 minutes, but whatever you need to do in order to, so that you can bring your best self to the next client or the next patient that you're working with, and just keeping track of that, keeping track of where your energy is and where your own mental health is and taking care of yourself. I think that's really important and we need to remember it on a daily basis.
So well said, Greg. And I just want to say, yeah, what Greg said, 187%. My last couple of thoughts are just thank you, Alex, and thank you everyone who was working behind the scenes and supported this. And just my other 4 panelists here, I do feel like I could pick your brains and just keep these dialogues going for so long. So thank you for being here too. And my last thought is just to challenge all of us to really keep the experiences of those we serve just central in our heart, in our decision making, that we're integrating the people we serve, their voices in the decisions that we make about them in policy. A lot of times we have decided as a system and the professionals that these are the things that we think people need. And I don't know that we always made the right decisions that way, despite well-intended thoughts and beliefs. So I would just really challenge us to think about those we serve and to really listen to them and to include them wherever we can.
Again, thank you to everybody. I'll echo those thanks. It's been really learned so much. I would just part with a couple of thoughts. One is wherever you sit tonight, there is probably close to you some move afoot to try and motivate mental health structures to respond to people in crisis instead of law enforcement. And this is true already for most people who look like me, who are from affluent settings or who are white or who have insurance. But in communities that are over-policed, this is a completely and stark different approach. And so we need to promote it. We need to think, when you hear about these novel applications of treatment for a health problem, really learn about them and support them. The other thought I would just leave you with is, wherever you are, there may be an opportunity for you to visit a jail or prison to learn about what's happening behind bars right near you. The FAM Foundation, who I really support, has a long-standing campaign with other groups to get people to go visit a jail or prison. I really invoke that for people who are in the mental health field who may not know the forensic space or the carceral space very well, but just to see what it is that people deal with in terms of level of treatment, and also all the new trauma that people absorb as they pass through these places. But again, thank you so much. This has really been a great educational time for me. Thank you.
Thank you all. I was thrilled when all 5 of you, agreed to do this. I agree that kind of you all work in different spaces, but I think we had some, great conversations tonight, and I certainly learned, a ton from all of you, and I'm sure the attendees did as well. With that said, Saturday starts Mental Health Awareness Month, and I just think this is the perfect opportunity just to kind of continue that learning that we did tonight, continue the conversation. Just remember it's, okay not to be okay, and to reach out. One of my favorite quotes is that, every system is perfectly designed to produce the results it gets. And so when we think of the current state, we need to think about the systems behind it, and how they're playing into the overall outcomes. So I encourage everyone to continue the conversation. Thank you for learning here with me tonight. There's some fantastic resources here. I want to thank our partner, CAHE, for partnering with us on this event. Thank my HASO fellow student council members. This wouldn't be possible without you. And for anyone that wants to connect further or collaborate, we certainly welcome that. So with that said, thank you all so much and have a fantastic night.